So let's start with data from Canada over the last 10 years. So this is a paper in 2008, a group out of Manitoba looking at 325 patients with diabetic foot ulcers. You can see the complete healing rate is about 40%. Ongoing healing, this is with at least 1 year of follow-up, another 20%, but 15% amputations over at about, I think it was a median of 1.4 years of follow-up, and a high proportion of mortality. 15% of these 325 patients were dead at about a year and a half. The other interesting finding, which I think we're becoming increasingly aware of, is the number of, or the disproportionate number of amputations that are occurring among Aboriginal patients with diabetic foot ulcers compared to those who are non-Aboriginal. So that's a major area of needed research that needs to be undertaken. Another publication here, this time out of Western, about 10 years after this last one, looking at 83 patients treated in a multidisciplinary team, healing rates of about 69% over variable follow-up, a few amputations, mostly minor, and a few deaths. This is a trial that was published in Diabetes Care. It actually looked at hyperbaric oxygen use, but we can look at the group that didn't have any hyperbaric oxygen to see what the natural history of diabetic foot ulcers are. And so these are ulcers that were at least present for 4 weeks. And among the 54 patients with quite a short follow-up at 12 weeks, about a quarter had met amputation criteria based on infection or pain, and another quarter had healed. Here's another study out of the Mayer Institute, 56 patients, very large proportion died, 20%. Quite a few also lost to follow-up, but pretty good healing among those who actually had ongoing follow-up at about a year. This is also another study documenting the benefits of multidisciplinary care and a better assessment in terms of vascular supply and bacterial infection and wound closure rates. And then finally, in a study looking across acute care hospitals in Canada and identifying an overall prevalence of 2.8% of all patients hospitalized for wounds. And this is a low number, and that's because diabetic foot ulcers, I think it reminds us that this is an outpatient problem, and the solutions to this and the data for this lie in the outpatient perspective, not a hospitalization perspective. And I think that's one of the problems with the lack of data that exists on this topic. In terms of cost, there are quite a few analyses of the attributable cost, but over $600,000 from the perspective of the Ontario Ministry of Health, and about $540 million across the country for all diabetic foot care. This is a paper that Ahmed Casey published a few years ago looking at confirming the fact that most amputations in Canada are being performed for diabetes, and a paper out of Ontario suggesting an increased amputation rate among diabetic patients among men and those with lower socioeconomic status. Finally, what's the risk of death in Canada? We said it was 50 to 70% at 5 years. This is a study out of Ontario showing that at 5 years, the mortality is about 50%, so the same as what we were seeing internationally, and about 10% of people are losing their contralateral leg after a major amputation. So moving on to other sources that aren't actually published. So Diabetes Canada has done a great job putting out some data. They're using a prevalence of diabetic foot ulcers of about 1.1 to 1.9% among all diabetics, and these numbers are available for each province. There's some interesting data that was available from StatsCan showing that a lot of people with diabetes aren't having their feet checked. So 30% of patients are never checking their feet with diabetes. This is from 2005. I couldn't find any updated data. And then finally, Health Quality Ontario's looked at the amputation rates among diabetic patients to see if what the trend in time is, and they suggested it's been decreasing among patients with diabetes, which is encouraging. But some of the work we've done has shown a contrary trend. So this is just a study of hospitalization patients, and at 7 hospitals in Toronto, 2 community, 5 academic, and we've shown that basically patients with diabetic foot ulcers who are hospitalized have much higher costs of care compared to other patients who are diabetic without ulcers, or the other top 5 most costly causes for hospitalization. So this is CHF, COPD, urinary tract infection, pneumonia. Amputation rate of about 20% here. And I mentioned to you, so Health Quality Ontario is reporting a lower amputation rate among diabetic patients over time in Ontario. But when we looked at the same data sets but changed the denominator to the general population of all Ontarians, what you see is that because there's a rising prevalence in diabetes, there's a rising prevalence in amputations due to diabetes. And so this is actually an increasing problem rather than a decreasing problem. And the problem really is one of geographic disparities. And so this is a map of Ontario showing the amputation rate across different health regional networks. And you can see in green are the lowest rates, up north in orange are the highest rates. What we're seeing when we're looking at within each region to see what's happening to these patients before the amputation, we're seeing that the highest amputation rates are in areas where patients aren't undergoing endovascular revascularization or improvement of blood flow. And they're also in areas where patients, or where there's the fewest concentration of chiropodists working. So we all know that part of the problem here is that there aren't integrated amputation prevention networks. We have regional cancer programs, we have regional trauma networks, we have cardiac care, we have dialysis. We just don't have anything for diabetic foot. And I know in Alberta there's been some exciting progress with this topic. We know about the benefits of limb salvage programs worldwide. If we think about how we might structure those around multidisciplinary centers with vascular care and chiropody, and plastic surgery and others, you see that where there's the greatest concentration of both vascular surgeons, chiropodists, and multidisciplinary experts, those are the areas where the amputation rates are already the lowest. So we need to come up with solutions to better reach out and overcome the geographic barriers to care that exist. And I suspect this map is true across Canada. Finally, just a quick note about end-of-life care. So we looked at all deaths in Ontario. And looked at those deaths to see who had diabetes and who had PAD. Most of them had diabetes. It's actually shocking, of all these patients who died, this is all deaths from any cause, 45% had diabetes, so huge. And when we split those deaths with diabetes in a small proportion with PAD between amputees, major amputations, so above the ankle, versus others who died from other causes, what we found was that in the last 90 days of life, healthcare costs for those who have a major amputation are very high. They're higher than across all areas. So inpatient care, outpatient care, medications, and physician services, much higher physician services if you've had an amputation in the last 90 days of life than if you haven't. But if you look at physician services for palliative care, and also including nursing care and home care for palliative purposes, it's half the number are receiving palliative care compared to other mostly diabetics who are in this control group. Half are dying at home rather than in hospital compared to a control group again. And patients who've had a major amputation are spending far more of their last few days of life in hospital compared to a control group. And when we looked at associations, we can see that there's a strong association between receipt of palliative care in the last 90 days of life and your likelihood of being at home and being out of hospital. So certainly there's a major area of improvement here. And I think there's a recognition in the world of palliative care that the scope needs to be broadened outside of malignant disease, and I think amputee patients who have diabetes are one of the, basically epitomize this need for palliative care. So finally, I'd just like to close on this paper that I found in my PubMed search, a nice summary of a problem in Ontario, and recommending that, as I think we can all agree, we need more studies to better characterize the organization of care and effectiveness of care for diabetic foot treatment pathways and prevention of diabetic foot complications. And then as Mr. Weiss says, we have all the pieces that are required. We just need to figure out how to connect them and how to coordinate the care better for these patients. So thanks very much.